Awesome. All right. Well, hello everyone. I'm Colleen. So I am a doctor of physical therapy here in Charlotte. So if everybody here is at least in the Charlotte area. I work outside of like around the Arboretum, as well as I work for one of the hospital systems here in the South Park area. But I have a lot of connections of a lot of pelvic floor therapists, and I've given Carrie a lot of the providers that I know and I trust that treat very similarly to me. So I'll go through a little intro about me. So like I said, physical therapist, I specialized in pelvic floor therapy. I born and raised in the DC area, and then I graduated with my doctorate from High Point University. I'm also a Pilates instructor. So, with part of my week, that is something I love to do, and I love to teach people Pilates. So, I do use that as part of my treatment process with a lot of my patients, especially when we're working on abdominal strengthening, as well as just pain as well. It can be a really great method of exercise to get back to things that people enjoy, and it's for all levels. So, it's been really cool to be able to combine that with my PT experience. And then I got my certification through Herman and Wallace, which is one of the governing bodies of pelvic floor therapy. So there are a couple out there, but that is where I was trained. And then one of the biggest things about me are my passions. So I love to talk about all things that nobody else wants to talk about. So I love to talk about sex and peeing and bowel movements and all the things that we feel embarrassed to talk about, even sometimes with our friends. So that is one of the biggest things is I want to make it more comfortable, more normal to talk about because everybody pees and poops and has sex, and it should be a normal thing that we can feel comfortable with. I am a big believer in how mental health and the physical health are just so connected to each other, especially with all the treatments that you all have been going through. I find there is so much tied to that nervous system that can be sometimes in fight or flight for a really long period of time that can take a toll on the physical. So we talk about that a lot with my clients. Um, I'm definitely a big proponent of trauma-informed care and all about consent. So yes, pelvic floor therapy can involve internal manual therapy as well as assessments, but not all of my patients feel comfortable doing so. And a lot of times when you're going through all of these treatments and you're being poked and prodded, it's just like, oh, one more thing. I don't want one more person touching my body. So sometimes we take a more external approach and we really might take a hands-off approach for care until they feel comfortable. And then one of the biggest things, the last thing that I'll talk about is I love strength training, and I believe everybody can utilize some strength training in life, no matter who you are. We just got to find the right entry point for you. And then I just shared a couple photos of showing me that I am a human. That is my dog Bosun. He is my fur baby I don't have any actual children. So this is my pride and joy. He's actually by my feet right now, taking a little snooze. And then that is my fiance, Brett. We love to travel. We're very big into the outdoors. So just a little bit about me. So we'll get into it now. So we're going to really talk about all things pelvic floor. So a little itinerary that I made for today. Number one, what even is the pelvic floor? So we're going to go through kind of anatomy. What does it involve? What are the functions of the pelvic floor? Cancer indications. So, right, a big reason why Carrie asked me to speak today is how does treatment impact our pelvic floor muscles, and what are common things that you all might experience, some of your friends might experience, people that you meet that might share stories with you. And then we'll get into kind of the nitty-gritty of what really goes on. So a lot of people will talk to me about incontinence or leakage when it comes to our bladder function as well as bowels, bowel health. So I talk and I treat a lot of people that unfortunately suffer from constipation. As well as a lot of medications can spark this journey for a lot of my clients undergoing treatment. Pain, that's one of the biggest things I treat, whether it be back pain, hip pain, pubic bone pain, pain within our cores, just throbbing pain or post-surgical pain. So many things that we can help with in terms of physical therapy. And then I brought some tools today to show and tell kind of like what kinds of things can actually be helpful for home. Yes, coming into treatment is so crucial for so many of my clients, but we are in the world of 2026 now. So there's so many things that people have made and created that have been honestly wonderful add-ons that people can actually do their own almost self-therapy at home. And then one thing that I did want to touch on that I get a lot of questions about is estrogen cream and how to talk to your doctor about it and the current updates with that. Of course, I'm a physical therapist, so I am not right prescribing estrogen cream to people, but sometimes I'm the first person that's actually looking at my patient's vulvar tissues and we're finding things that I'm like, hey, like, let's bring this up to your doctor and see what the options are. Let's work with oncology, let's work with your doctor, let's figure out what kinds of things can really benefit the tissue that might be either irritated or affected because of either radiation or chemotherapy or surgical indications. And then we'll go over questions. So, again, nothing in my realm is too much information. So, I promise you, if you have any question, like write it down throughout the presentation. I find like even the smallest question, sometimes another person is thinking it. So, never feel embarrassed. And then, of course, I'll give my contact information at the end of the presentation. So if there are any questions that you don't want to ask in front of others, then you can always email me. All right, let's get into it. So, what is even a pelvic floor? So we talk about it. Um, Most of my clients that come in that have never heard about it really, but all I've heard is Kegels. Okay, whenever I hear pelvic floor, I have someone like, "Oh, I should be doing my Kegels." But a lot of times that's just oversimplifying things. So we're going to go through today the actual functions of the pelvic floor. So it's not just about squeezing those muscles, but there are actual five functions that we learn in PT school. One of the biggest ones is support. So I brought my pelvis with me as kind of a demonstration, but the muscles, right, of the pelvic floor are the actual muscles externally. So all of this red muscle here. So this is the vaginal opening, this is the rectal opening. These are your sit bones, your pubic bone, as well as the tailbone. So all that red muscle attaches like a bowl. And if you can see on the inside, it's basically acting as a little trampoline or even like a little hammock to all of our organs. So it has to be really strong, but also really flexible to be able to hold up all of the organs, right? Whether you have a uterus, whether you have right bladder, you have all of your intestines. So it has to have enough support to be able to hold everything in. And so everything doesn't just fall out of us, right? So, fun fact, men and women both have pelvic floors and they are supporting all of our organs. Next function is about sphincteric control. So this is the function that we think of when, we're trying to hold back urine, we're trying to hold back gas. All of us have probably done a Kegel to be able to not let a fart out here and there, right? So that's what the sphincteric control. Sexual function, a little bit self-explanatory. Some people might think it's just based off of, right, having penetrative intercourse, but it's actually has the biggest function is orgasms. So I have people come into my office all the time. They might not be having pain, they might not be having anything they think is wrong, but as soon as I ask, "Hey, how difficult is it for you to have an orgasm?" They're like, "Oh, I've never had an orgasm," or "It takes me a really long time to have one." So that's something that we work on in physical therapy as well. Um, Next function, stability. So I mentioned a little bit earlier that I treat back pain, hip pain, pubic bone pain. So the pelvis itself needs to be a really stable environment because it's the center of our body, right? So we have our abdomen up top and our arms and our diaphragm and our rib cage. But then at the bottom, it has, right, our knees and our ankles. So the pelvis itself has to be really, really stable. And if it's not, then we can start having things like back pain, knee pain, foot pain. So everything, big believer that every part of your body is connected. If you've ever heard the song, right, the arm bone is connected to the hand bone, go so on and so on. It's all true. And then last function, a lot of us don't think about, but when it comes to cancer treatment, I find this is one of the most important functions is sump pump. So what does that mean? If anybody's ever heard of the lymphatic system, your pelvis is actually a pump to that lymphatic system because of so many muscles and so many vascular structures, meaning like arteries and veins going through the actual pelvis. If there's any sort of injury or radiation or surgical repair in the pelvis, it can actually change how that lymphatic system functions. And you can end up with things like lymphedema or pelvic congestion disorder. So we work a lot with those patients as well. All right, so that's kind of my nitty gritty about the pelvic floor. And then I just wanted to show you another little couple pictures about, okay, where are these actual muscles? Now, on the left-hand side, that is the male pelvic floor. On the female side, on the right-hand side, that's the female pelvic floor. You can see they are so similar, especially towards the bottom of that pelvic floor. So it's almost identical in what we call the posterior aspect or towards the rectum, right, where we poop all the same muscles. As well as in the front, most of them, again, are the same. The only difference is, of course, we do not have a penis and they do not have a vulvar opening, but all the muscles act very similarly. So everything that's colored is a muscle. And then this is another great picture that shows more of that support of how much it really does have to provide a lift and a hold, but it has to also be very flexible to be able to withstand movement every day. So it attaches from that pubic bone all the way to the tailbone. So if you've ever experienced tailbone pain, or sometimes people, unfortunately, especially with the ice that happened a couple weeks ago, I've had a lot of patients fall, unfortunately, and start having that tailbone pain. So a lot of times that can be due to pelvic floor muscle tension, really pulling on that tailbone. And then we'll go through some other things now. So one of the biggest things, like I said earlier, Carrie wanted me to talk to you all about is how does cancer affect the pelvic floor? And it affects it quite a bit. So I want to go through three things today. Of course, we could probably talk about this for like 4 hours. And I know there's a lot when it comes to different treatments, but I want to give you really the basics of how we look at it and how we treat it. The first one we'll go over is how radiation can affect the pelvic floor muscles. Then we'll go through any surgical indications and how different surgeries are. I heard someone earlier even talk about the deep flap surgery. And yes, I have treated many clients, especially having abdominal discomfort and abdominal pain, as well as doing myofascial release after surgery. And that can be a really, really helpful tool. And then lastly, chemotherapy. All right. So radiation. What happens, right? What happens when we have radiation? So, I mean, it really depends on, of course, where the radiation is being targeted, like what tissue is even being affected. But I would say one of the biggest things that we see, at least in the pelvic floor world, we might not be seeing as many breast cancer patients radiation. Those are going to see my great colleagues that are more probably lymphedema therapists. And there are therapists out there that specialize in breast cancer rehab and being able to do myofascial work there. But I'm going to treat people that have more radiation maybe to the abdomen, to the pelvis, especially directly to the pelvic organs. Unfortunately, right, a life-saving treatment option, but it can cause a lot of other symptoms. So it can cause a lot of nerve injury. It can cause hardening of the tissue, or rather what's called fibrosis of the tissue, decreased tissue elasticity, decreased vaginal length, as well as vascular injury. This does not happen to every single patient. I have to say that with a disclaimer. I have had many clients that have had pelvic radiation and they have done wonderfully. But unfortunately, some of these direct injuries can occur. Also, length of time, how long the treatments had to go on, if there were multiple rounds. All of that plays a huge role. But one of the biggest things, what does that cause, right? It can cause pain. That's one of the biggest things that I see when I treat my patients that have had direct radiation to my pelvic organs is pain with intercourse. A lot of times it is because it shortens and hardens that vaginal tissue. And that's when we really need to be working with a great GYN in terms of talking about different creams, talking about different topicals that should be actually being applied to the tissue after radiation. Pain with pelvic exams. I don't know about you. One of the biggest reasons why I even got into pelvic floor therapy was because I, as a teenager, thought that pain with pelvic exams was normal. I remember my OB/GYN was like, oh, this is going to hurt a little bit. And then once I experienced being a patient as a from a pelvic floor therapist, and I learned that, hey, that's not normal. We can actually do something about that. Guess what? No more pain with pelvic exams. So that's what we do with our clients is how can we find strategies to make these exams as less painful and less traumatic as we can because right life and what we've been through is probably already traumatic enough and we do not need to suffer as women, absolutely not. And then one of the other biggest things is urinary and bowel difficulty and or leakage. So it can range. It can range from maybe the tissue is becoming so tight and maybe the tissue is becoming so decreased elasticity that it's actually contributing to not being able to release stool. So I see a lot of constipation after radiation, but then I have seen in the opposite direction where it inhibits the actual muscle function and it can create that pelvic leakage afterwards. There are so many strategies, again, that can be really helpful. I have a great colleague that does more what's called a bowel retraining, and it's a specific technique that can be really helpful post radiation. But a lot of times it's just learning how to work those muscles again, doing some internal release work, and then teaching you how to relax them on your own. Um, we already went through how we treat. So I said just now, we go through a lot of soft tissue and manual therapy techniques. So what does that mean as a pelvic floor therapist? Does that mean that I'm going to be massaging your pelvic floor? Honestly, kind of, but in not a weird way. We're going to teach you how to do it on your own as well at home, and then teach you how to physically actually relax those muscles. Again, I don't know about any of you, but I was never, ever, ever taught how to relax my pelvic floor. I was only told how to contract my pelvic floor. Kegels are for everyone. A lot of times, Kegels can make symptoms actually worse. So we're going to go through kind of that as well as we go through questions today. And I said earlier, we work with doctors if we're finding a lot of tissue irritation. If the tissue is bright and red and just angry, then we're probably not going to be pushing on all of that tissue, right? It's going to make it angrier. So we need to make sure that we're finding topical creams and things that the doctors are like, okay, we need to be applying this either every day or every other day until the tissue kind of calms down. So most GYNs, at least in the Charlotte area, are great at finding out what works for you. And then muscle training and relaxation techniques. So, like I said earlier, some of my clients don't feel comfortable doing any internal work with me, and I'm totally fine with that. I think there's so many different entry points, and sometimes less can actually be more. So, we look at it from more of an external perspective. How are the inner thighs moving? How is the low back moving? Are all of these other muscles that are connected to the pelvis actually pulling on those internal muscles and causing some of that discomfort and some of that pain? And can that actually help? We can use things like lacrosse balls and tennis balls to do even like your own self massage for home that's not internal. So a lot of my clients that just don't feel comfortable doing it, that's what we'll do. And then moving forward to surgery. One of the biggest things that I treat, and this is, yes, can be related to cancer treatment, but a lot of times, sometimes it's not related to cancer treatment, is hysterectomy. So that is a very, very common surgery. And I see more and more that people are being referred to pelvic floor therapy, but it breaks my heart when I meet someone that had a hysterectomy maybe 2, 3 years ago, and their doctor never even brought it up that pelvic floor therapy can be an option. I really am a big believer in, we send people to post-surgical rehab for knee replacements, hip replacements, back surgery, foot surgery. Why are we not sending them when we're removing an entire organ and actually cutting open our abdominal wall? So I find there's so many things that can go awry when we are removing an actual organ. And also it matters whether we're having a, partial hysterectomy where we're taking just the uterus or a total complete hysterectomy where they are taking the ovaries and the uterus. I'm seeing less and less of total hysterectomies, but again, it depends on the patient. Um, it really interferes with how the pelvic organs sit, right? So just like, even for men, we treat post prostatectomies or prostate removals. When you're taking a whole organ out of the pelvic cavity, it's going to interfere with how all of those ligaments, all of those muscles actually are working. There's now a space that is there that was not there before. So your organs are going to shift and they're going to move and they're going to find its new normal. So it's not uncommon that a lot of the muscles can actually start tightening up to basically provide that extra little support. So a lot of people will say, oh, I didn't think that, oh, when I had my hysterectomy, I started leaking afterwards. I thought it was because my pelvic floor muscles were weak. Actually, your pelvic floor muscles were probably more tight. And then when you went to cough or sneeze or laugh, there was no room for it to actually contract to be able to hold back urine. So it's a very common misconception again, even with post-surgical patients. One of the other biggest things when it comes to post-surgery is risk of nerve and vascular injury. So unfortunately, not all surgeries go to plan, and sometimes it can contribute to nerve injury. Whether they are, temporary nerve injuries or whether they're complete nerve injuries, I promise most surgeons that are doing pelvic surgeries are probably very good at what they do. I really, in my career, have not seen many complete nerve injuries, but I have seen a couple where, they might lose sensation for a little bit and it takes a while for them to gain sensation back, or things feel a little bit numb for a couple months after, and then nerves actually can repair and heal. And then the last one is really disruption to the fascial layer of tissues. So if anybody's never even heard of like what is fascia, right? We talk about, or if you've ever seen a fascial therapist or your massage therapist are like, you have really tight fascia. What they're saying is you have a very thin layer of connective tissue over muscle. It basically, I like to think of it kind of like a spider web. You know how a spider web, it is so strong, right? All those tarantulas and stuff are able to walk on it and do all the things that they need to do. But it's supposed to move very, very nicely with our muscles. Anytime we have a surgery, it's going to cut through that layer of fascia and really interrupt how it moves. So it can make things feel stuck and sticky and just not great. So, and that goes a lot too with my breast cancer rehab patients. A lot of times, right, when we have mastectomies, the fascia is what is really playing a huge role. So again, I think I've given Carrie a couple of people that I know and I trust, but we can always go through that at the end too. But I like to think of it kind of like if you had a wrinkle in your t-shirt, right? And if this is where my surgical scar is and I'm pulling, and this is super tight, it's going to affect the whole rest of the actual body, especially in our abdomen. So people might have, right, especially like a C-section scar, they're going to have that kind of pulling around the scar, but it can actually affect more the upper abdomen as well as below the abdomen. So what do we do about it? What do we do to help these patients? Soft tissue is fabulous. We really do work on scar mobility and scar tissue, and it's been really shown to help. And then teaching you how to do it on your own at home too, like not being shy and not being scared to touch scars. One of the biggest things that I see with most of my surgical clients, whether they're coming for pelvic floor or whether they're coming for a knee replacement, is like, oh, I do not want to touch that scar. That is just like, it gives me the heebie-jeebies. And that is so normal, right? So getting used to it, desensitizing the tissue and making sure that you're being able to progress and get better. Um, Next, we did talk about not just Kegels, right? So strengthening the pelvic floor muscle does not just mean Kegels. There's actually great research out there that's kind of come about in the last, I would say, 10 years, and especially in the past 2 years, there's been excellent research of showing there's better pelvic floor activation and contraction with people who are doing active strength training. So people who are doing squats, lunges, clamshells, things that are actually getting like your bigger glute muscles and your hamstrings and your quads more active than people who did Kegels alone. So we find more functional exercise is actually better for our pelvic floor than just sitting at a stoplight and squeezing your pelvic floor on and on and on, which I really don't want any of you doing. And then last one is education on supportive devices such as a pessary. So unfortunately, right, when we do have an organ or things that have been adjusted or removed, sometimes it can not have a lot of support, especially if the ligaments are not strong. I find a lot of my clients that have unfortunately been through radiation and surgery have a lot of difficulty with their ligament strength because the tissues have all been affected. So, as long as they're using some sort of cream that is building back that lubrication, that their tissue isn't super, super thin, typically we work with your GYN, especially a urogynecologist, to think about fitting you for a pessary. And then we will go over that if nobody knows what that is, but it's basically a supportive device that can go inside the vaginal opening to support if you're feeling any feeling of pressure, whether it be the uterus or the rectum or the bladder. All right. Let me just grab a sip of water. All right, so let's go through how chemo can affect it. I mean, there's no good news about chemo, I have to tell you. But the only good news is that it doesn't affect directly to the muscle itself in the pelvic floor, right? Unlike radiation, we're not sending chemo directly into the muscle tissue. So that is a good thing in terms of that. But it unfortunately can induce early menopause, right? Especially if it causes more of the ovarian failure. Then, yes, that can definitely affect the muscle. And what we know about menopause, right? When we have decreased estrogen, that actually inhibits how well our muscles can build strength. So I work with, yes, my patients that have been undergoing treatment, but also my patients that are undergoing menopause without any sort of treatment. I'm really focusing on strength training, good nutrition, making sure you're getting lots of water, protein, all the things that are going to keep you building muscle throughout life. Peripheral neuropathy, that's one of the biggest things. And again, if you don't know what that is, basically, it's a nerve injury to what's called the peripheral nerves, or the nerves that are extending away from the spinal cord. And it can basically cause like numbness, tingling, especially my clients might get it into the feet and the lower legs. That is usually where we find it, but you can also have peripheral neuropathy into the hands. So that's going to affect right balance. That's going to affect how well you can tolerate feeling things and making sure that we're not injuring our feet. If you step on something, sharp, you might not be able to feel it. So we want to make sure that those patients are staying safe and then we're not having any injuries there. Deconditioning, one of the biggest things that happens during chemotherapy. You're feeling like crap, you're not exercising, you are probably doing it for a couple of months. I know with my own mother, when she went through chemo, there was no exercise happening except from getting up in the morning, right? And trying to just move about her day. So there was a lot of deconditioning afterwards and loss of muscle mass. So we want to really work towards building that back up, especially if we can do a little bit during treatment, if we can tolerate it, and if it's approved by our oncologist. But of course, if we need to wait till after treatment is done, then we will hit the ball rolling as much as you can tolerate. And again, like I mentioned at the beginning of my presentation, I'm a big believer that there's always something that we can do. Um, we just got to find out what it is. And then hip pain and back pain. So I do see a lot of people, especially after they've had, unfortunately, a lot of deconditioning or weakness, start to have hip pain, start to have back pain, start to have just joint pain overall from that lack of movement and lack of stability. So we might work on soft tissue techniques to help with decreasing soft tissue and tightness and pain. And then lastly, we went through kind of treatment already, progressive strengthening, soft tissue techniques, and then also really getting you to see the appropriate providers. I have heard horror stories from some of my clients that just didn't feel supported by their doctors, or, after they were done with treatment, they're like, where do I go from now? It's great. I've had a lot of clients that are starting to utilize more of like the Levine's program. They've been able to take strength classes and yoga classes and all the nutrition advice afterwards, still at the Levine Center. But again, not everybody can make it all the way to Uptown Charlotte. So, hey, how can we find you really great care close to where you live? All right. And then we're going to go through all the things that I get the most questions on in terms of pelvic floor. So one of the biggest things that people talk about is leakage. I don't know about you. I have had urinary continence. You do not need to raise your hand, but one of the biggest reasons why I became a pelvic floor therapist is at the, ripe old age of 20 years old, I was having stress urinary incontinence with running and jumping. And as an athlete, I was actually told it was normal until I found out, hey, I think all these symptoms are actually my pelvic floor. So, yes, stress incontinence is when there is a stress added on to the actual muscle that basically there's too much pressure that the muscles can't withstand. I mentioned earlier that it can actually be a tightness issue and not necessarily a weakness issue, or it could be a little combination of both. So I like to say two things can be true. Muscles can be tight, but they can also be weak. And that's usually what is happening. Typically, once we learn how to relax the muscle, then the muscle can actually go through its full contraction and be able to actually strengthen, right? So that's one thing that we treat in pelvic floor therapy. Another one is urgency, especially when it comes to pelvic floor tension. This is one of the biggest things that I see is people running to the bathroom all day long. And I even was talking to my mom about it the other day. She was like, "Oh, I have to pee all the time." And, we talked about different things, how normal going to the bathroom to urinate is every 2 to 4 hours. So if you're going, less than every hour or every 30 minutes, there's probably something going on with the pelvic floor that's contributing. We talk about bladder irritants, alcohol, carbonated beverages, which I am guilty of right now. I love a spindrift, but that can actually increase sometimes people's urgency to go to the bathroom. Soda, you wouldn't be surprised what can actually come about when we go through our history of what could be causing this urgency. And then mixed, the lucky people can have, unfortunately, both levels of incontinence. So in our office, right, we kind of went through a little bit of treatment that we do, but a lot of these clients benefit from learning how to relax the pelvic floor, making sure that, hey, like, is this because a muscle is too tight? Is this because a muscle is too weak? Are we going to add a combination and give them a really individualized approach versus, again, just sending them home with Kegels when actually Kegels has been shown to make sometimes urgency incontinence and stress incontinence worse? All right. And then bowel health, constipation. Oh my gosh, who doesn't love to talk about poop, right? Super, super exciting stuff. So here's my cute little Bristol stool chart. Just maybe some of you guys have had this seen in the past, but it basically tells you what your poop is supposed to look like. So you can see number one, right? Our angry poops, that is the constipation poop. And our sad poops, the diarrhea that we probably have all experienced when not eaten something good. Now, your poop should never look like number one. It should never look like number seven. Our star poop is number four. So we want our poop to be nice and long, nice and form. It should be easy to pass. So if I'm having clients that are like, oh, my doctor told me pooping once a week is normal, I'm like, no, that is not normal. We should be having a bowel movement every day. Of course, there are certain diagnoses that I find can slow down gut motility, especially if we've had abdominal surgeries. I'm okay with maybe every other day or every 3 days, as long as the stool is well formed, it's soft, it's not hard pellets. But if it starts to turn hard, that tells me that stool is just sitting in your gut too long to the point that your gut is now absorbing the water out of it. So we talk about water intake a lot with my patients with constipation. So our goal, and I am guilty of it too. I did not drink as much water as I wanted today. But it's about half of your body weight in ounces of water. Of course, we tell our clients to go slow to get to this goal. So if you see that and you're like, oh my gosh, I have like 2 glasses of water. Don't go out tomorrow and start chugging water because your kidneys are not going to love that and you're going to be in the bathroom all day long. So we want to be slow, we want to be progressive to um, be able to drink a lot of that water. I like to look at fiber intake with my clients. We could probably do a whole hour on fiber and nutrition, but again, I counsel my patients, but of course, I'm going to, if I feel like there's something nutritionally wrong, we're going to look at working with one of my dietitian colleagues that's really, really great. A squatty potty. So, if you've never heard of a squatty potty, I think everybody and your entire family needs to have one in your house. It is a step stool that you put right underneath your toilet to lift your feet up to be able to relax those muscles. Super, super helpful. And then lastly, we go through the abdominal massage. So, especially with my clients that might have that slower gut motility, that might have abdominal surgeries, we're going to teach them how to do abdominal massage to help with bringing more blood flow to the colon and get things moving through the system. And then lastly, the nervous system. So, I don't know again if anybody's ever experienced this, but travel constipation or feeling like, oh, I have like something really, really stressful going on, and I notice my constipation gets worse. So, our digestive system and our nervous system are very heavily connected. So you can actually research on your own the gut-brain connection. It's very, very interesting, but we're seeing more and more people start to figure out, oh, if I can get my stress levels a little bit better under control, I poop so much better, which we love that. All right. And then we'll go through some pelvic pain. So I mentioned earlier that we treat low back, tailbone, hip pain. So we kind of went through that already. Again, I could probably spend a whole presentation on just that alone. There's so many things that are involved, but a lot of times it's due to sometimes an imbalance of certain muscles being really weak, certain muscles being really, really tight. What kinds of activities are aggravating these again and again and again? Like I had, oh, okay, I'm thinking of my one client. That had tailbone pain, and we finally figured out what was going on. I was like, why is your tailbone pain not getting better? And it turns out they were having to go every night to their son's basketball games and sitting on these hard bleachers. So they were doing all the right exercises, doing all the right, work and trying to stand throughout the day. But then it was just coming back. And so all we did, hey, we just purchased a really nice little cushion pad so they could still go to their son's games. And then it didn't bother them as much. And then we could still make progress. So I find there's so many interesting little things that can actually go into people's pain. Vaginal dryness and estrogen loss. We talked about that a little bit, but one of the biggest things when I see my clients that are going through any sort of cancer treatment, a lot of times it causes that vaginal dryness and as well as induction of menopause, estrogen loss. So I will talk about that a little bit more, but that can cause quite a bit of pain for some of my clients. Increased tone of the pelvic floor muscles. So again, if the muscles are too tight, then it can cause muscle spasms. It can actually radiate down into the butt cheeks or down into the thighs. So sometimes the internal muscles can actually have symptoms outside of the pelvis. And then lastly, post-surgical pain. And we talked about that a whole lot earlier. So we'll talk briefly about estrogen cream. Again, disclaimer, again, like I said earlier, I am a physical therapist, so I am not prescribing estrogen cream to patients, but sometimes, like I said, I'm the first person that even mentions it to my patients. And I don't know if you're keeping up with the news and the FDA and the great urologists that have actually just removed the black box warning on topical estrogen cream for a lot of cancer patients. It has been such a wonderful thing. So I really highly recommend if you haven't talked to your doctor about it or you're not doing your own research and talking about, hey, is this the right treatment method for me or is it not? And it still can be not for some of my clients. So that's why we go through the different options as well and what you feel comfortable with. So a lot of my clients that unfortunately don't feel comfortable or cannot use estrogen cream is they're going to maybe be using hyaluronic acid. So there's a brand called Reverie that's very common. And then one of the other biggest ones that I see is Intrarosa. So it's a DHEA, which does, you talk to gynecologists and oncologists about it. There is some estrogen properties there. But again, I am not the expert in this. But we can kind of go through what the American Academy of Gynecology's current position is. So their basically consensus is that low dose vaginal estrogen can be used in individuals with a history of estrogen dependent breast cancer. So very huge news when even 5 years ago, I was seeing patients and their gynecologist or their primary care provider was like, absolutely not. So again, I highly recommend looking up, and we can talk about this more. Dr. Rachel Rubin and Dr. Kelly Casperson, those two urologists have been really forefront with working with the FDA and working on getting estrogen helping their cancer clients. And then we'll go through little things that might pop up or might actually hit home for you. Um, I unfortunately get to hear all the bad things before people start to get better in my office. So when people have told me, they're not being listened to, maybe common things that you all have heard is, oh, it's painful, just use lube, right? That's not helpful, right? Yes, lubricant is can be helpful, and there are so many different types that I love to talk about because it's a whole new world for so many people. But then, like I said earlier, there's a lot of topical creams that are more necessary to let that tissue heal. Um, I've had even, unfortunately, some clients that, they brought up having painful intercourse or leakage, and their doctors are like, well, just be thankful, right, that we're still here. And I'm like, no, if we're not having a good quality of life, then we can't, right? What's the point? So there are so many things that can cause these symptoms, but guess what? There are so many things that can help these symptoms. Um, Yes, I've heard the horror story, have a couple glasses of wine, just use liners and diapers. Leakage at any age can be helped and minimized. So no matter how old you are, I treat patients from their teens all the way into their 90s. So if you're knowing someone that's, embarrassed to talk about leakage or isn't going out to lunch with friends because they're scared that they're going to leak, hey, maybe send them my information and we can point them to a great pelvic floor therapist. And then make sure you do your Kegels to help with leakage. Again, we talked about this quite a bit because I want to hammer it home, but sometimes Kegels can actually make these symptoms worse or be a very small part of our treatment process. So if you are doing a million per day, please stop. So that is my conclusion. It was so wonderful being able to share this. Again, like I said, I could talk about this all day long if I was allowed to. So it is never too late to begin pelvic floor therapy, whether it's with me, whether it's with one of my colleagues. Again, there's actually it's such a growing field, especially in the Charlotte area. So know that there's going to be someone out there that can help you. You do not need to live with pain. You do not need to settle for leakage or constipation. All of these things are able to get better. And then as we go through questions, again, there's no question too small. And don't feel embarrassed. And if you just don't feel comfortable talking in front of everybody, then again, I'll give you my contact information in the chat so you can always message me. Thank you.
Perfect. Thank you so much, Colleen. It's great to have you. We appreciate your time.
Thank you.